speaker today is Dr. Hendry. He comes to us from UC Davis Health, where he is the Associate Vice Chancellor for Health Equity, Diversity, and Inclusion. So thank you so much for coming to us virtually, and we look forward to hearing your talk.
Thank you very much. I am really delighted to be able to present some thoughts I have around race that really, I think, dovetails into what Dr. Berry said about the complexity and evolution of our understanding of race and how we use it in research. I'm going to go ahead and share my screen right now. Okay, so so I think we see a lot of evolution in race because in the definition of race, because race actually is a social construct. And I'll go into a little bit more detail of what a social construct is. The United States has had a pretty complicated and long history with the term race and racism. And I want to just give you first a brief timeline of the concept of race as it has emerged, particularly in the United States, but actually the United States has been a primary driver of how the world thinks about race as well. So in the late 1600s, the U.S. actually enacted a law that differentiated European and African servants and said that African servants, people with black skin color, were permanently slaves. And so what that meant was that even if you were to be able to buy off your servitude if you were white as a black or African servant, you could not buy that off, and your children would inherit the condition of enslavement. And so this was one of the first instances where your skin color actually connoted you being enslaved, and that could be passed down through the generations. Now, in 1776, Blumenbach, who was an anthropologist, characterized 5 distinctive races based on skin anatomy and skull anatomy and skin color, and characterized the Caucasian skull as being the most beautiful skull. And while he himself was advocated for anti-slavery, his statements around this perpetuated and created this idea of a hierarchy amongst races that was based on biology. In 1839, Samuel Morton concludes that Caucasians are intellectually superior based on brain cavity size. So again, starting to equate some pseudo-scientific biological characteristics with this notion of race. In 1990s, we started the Human Genome Project, and what we found there was basically refuted the past notions that there were these significant biological differences between these so-called races. And what they found was that there were more intraracial differences than there were interracial differences. And what they did was an example was they compared 2 famous geneticists who were white and found, and also another well-known Asian geneticist, and they found that the one of the white geneticists and the Asian geneticist had more in common in their genome than between the 2 white geneticists. Again, as an example of what they were finding consistently, that there were not very many distinctive interracial differences when compared to intraracial differences. In the 2000s, with the Surgeon General's report on health disparities, we saw a proliferation of health disparities research that stimulated the creation and use of race-based therapeutics. So this is where we saw, medications that were geared towards certain populations, certain racial groups, actually. We also saw the creation of algorithms, such as the race-based EGFR algorithm that sought to incorporate race into it with the intention of improving care. But as many of you may be aware of, it's resulted in perpetuation of some inequities as well. Now, the problem with defining race by genetics is multifold. So, number one, genomic studies, as I mentioned before, don't really support a genetic definition of race. The other thing is that these so-called biological differences in races have been used to justify human rights violations. And the picture that I have on this slide is of Miriam Sims. And Dr. Sims was has been characterized as the father of gynecology, and he did a lot of work around vaginal fistulas. What he did was he conducted operations on enslaved women, Black women, without anesthesia, and and his rationale for that was that he believed that Black people had different ways of processing pain, and so that they didn't require anesthesia. Now, as outrageous as it may seem to us today, it wasn't so long ago when there was a 2016 study that actually looked at medical trainees' attitudes towards pain. And one of the things that this paper identified was that many medical students in their fourth year, a significant number, I would say not many, but a significant number believed that Black people process pain differently because they had different kinds of nerve pain receptors. So this so-called biological difference is still, even in the modern era, has taken some hold. Therapeutics that are based on genetic racial differences have actually yielded marginal efficacy and has even exacerbated health inequities in a number of cases, like EGFR, where the estimation of GFR has led to barriers for Black patients to get transplantation. Attributing health disparities to genetic differences, and this is a big one as well. When we attribute health disparities to genetic differences, it distracts us in medicine and healthcare from addressing the core issues, which is racism, bias, stereotyping, lack of trustworthiness, and structural inequity. It's only when we've started to think about race as a construct that we've started in the medical field to think about, well, why is it the case that there are these racial differences? And given our understanding, we are starting to look at, well, maybe it's not biological differences. Maybe it's actually discrimination and structural and racial inequities that have, impacted minoritized communities. So what is a social construct? A social construct is a human invention. It's a human invented classification system that helps us to define, understand, and have some mastery over our experiences and the world around us. Excuse me for the misspelling of world. An example, and it's not to say that social constructs are fake or they have no impact, that they don't have any weight, that they're invalid. No, social constructs are incredibly powerful organizing and drivers of our of human society. Some examples of social constructs: money. It's actually in reality just a piece of paper, but it has a lot of meaning, and it's in many ways it has powerful meaning in how we experience, live, and interact with one another. Another example: our country. A nation is a social construct. There are no physical boundaries that separate countries by and large, but it's separated, it's distinctive by a concept of nationality and national boundaries, and groups of people living within a social and cultural boundaries of a nation. So race as a social construct helps us to understand why are there these differences between people, and why do these what are these differences and why do they exist. Also, race as a social construct has helped to the way that we construct race is hierarchical, and it often is used as a tool to justify, create, and perpetuate racism. So race can be a tool to justify, create, and perpetuate racism. So here's an example. Um, the words that we use, that we attach to white and black, which are racialized adjectives. The white lie. Maybe the tooth fairy was tired and overslept last night. That's why there's no. The idea that if it's a white lie, it's a harmless lie, and in fact, it might even be a beneficial lie. Versus the word blacklist. When you're blacklisted, it means that you're sort of put on a list where no one wants to be. How do we come up with these terms? White lies, blacklist. Well, they're socially constructed and they're associated with our biases and stereotypes around what race is and where people are in this hierarchy of race. So given the problems that we have with race and the abuses that medicine and healthcare have done using race as a tool, should we eliminate all references to race? Well, let's think about that, because there has been some discussion and dialogue around doing that. Let's eliminate race from everything we do. Let's make it race blind. Well, let's go over the history of these kinds of models of care. So, in the days of Dr. Sims, we used race-based medicine. We used it in a way that was overtly racist, where we experimented on Black and brown people. We noted that they were distinctive in their biology, and then we sort of bounced away from that and said, well, everybody's treated equally. We'll just treat everybody the same, understanding that most of our research subjects were white and not people of color. And then we bounced back and used race-based medicine, which is understanding that, again, with this understanding that race is a biological concept, and that we would try to incorporate different races' biologies in our therapeutic. And now we're at the point where we're considering this idea of anti-racism medicine or race conscious medicine. So the race blind approach is that everybody's treated the same, race is not considered. The problem is that this approach assumes that we're bias free. And the research that many of us know, we understand that there are disproportionate impact that disease has on minoritized groups. Race-based medicine, again, is this idea that that the differences are a result of biology, and it conflates race with racism. Anti-racism or race-conscious medicine understands race as a construct and focuses the interventions on examining the impact of racism on people. So it's not that there are inherent biological differences, but racism can create biological, social, health differences. And here's an example. Structural racism can have a social determinants impact. It can also have a biological impact that leads to altered kidney physiology. So I'm going to conclude with a framework that we are using at UC Davis Health. We call it the Be Fair framework to assess, implement, and redesign programs. And so, the first step that we use is to incorporate an anti-oppressive perspective. That has to be something that we uplift and center on, because if we don't, then it would be forgotten. It would be overlooked. We need to engage diverse partners in the project design because they may have insights that we might not have that have implications on minoritized populations. And then to specifically identify and address the project implications on historically and locally marginalized communities. Again, we want to center that because if we don't, um, marginalized communities will tend to be obscured and forgotten or considered less unless we make it a point to do so. Assess inequities through disaggregation of cultural and socioeconomic data and aim for equitable outcomes. Again, being very conscious and deliberate about addressing this. Otherwise, it could slip through the cracks. For project implementation, it's not just enough to design a study that is that has equitable methodology, but to design intervention that address bias in the deployment, in the supervision and implementation of projects. And then to, we're not done and we need to incorporate regular quality improvement measures that that also look at equitable outcomes and processes. And then finally, utilizing the lessons that we learned on a particular project around structural inequities and applying that to our organization in a broader sense. So this is where we think about what is the implication, what have we learned on this particular project that we can use to advance an organization through its policies and practices that is anti-racist or addresses structural inequities. Thank you very much for your time.